It's privilege to be in front of you, and I'm talking on a topic that is very close to me. And I have done a lot of work in the insulation in Himalayas in the northern part of India. Let me tell, the insulin being the oldest, natural, most potent anti-diabetic drug, but the sad part is that it is the least used medicine in the treatment of diabetes. So here is a real world scenario. Here is Mr. Singh, who is 49 years. He is horticulturist by profession from rural village of Himachal Pradesh. Presented in my OPD 3 months back with fasting plasma glucose of 190, postprandial 302, and A1C of 10. The serum creats of 1.6 and his EGFR was 52 with background retinopathy. On asking, he revealed that he is diabetic since 2010. He presented in May 2010 with his primary care physician with fasting plasma glucose of 156, postprandial glucose of 230, and A1C of 8.4. His primary care physician treated Mr. Kumar with metformin 1000 milligram twice a day and pioglitazone 15 milligram twice a day. He came back in April 2011 with a fasting plasma glucose of 149, postprandial 230, and A1C of 8.7. Treating physician added glimepiride 2 milligram to the pre-existing drug regimen. In September 2020, his fasting plasma was 160, postprandial was 248, and A1C was 9.3, and treating physician increased glimepiride to 4 milligram. In October 2015, his fasting was 190, PP was 302, and A1C 98, and the tablet teneligliptin and Ogli was before each meal was added to his existing regime. I think everybody who's viewing me is a usual scenario of the treatment of diabetes in India or world over. But the worst part is that on asking, he told treating physician never discussed the option of insulin within last 10 years. So these are two scientists whom I salute. Every day I salute them, Benting and Best. They deserve for that. And according to me, insulin is a gift from God to humanity and is literally a divine intervention. And that insulin changed the history and destiny, not only of type 2, type 1, but type 2 diabetic patient. Because in 1921, when insulin was discovered, there was no oral hypoglycemic agent. So it was a treatment only option for type 2 diabetic also. With the availability of the oral agent in 50, the first oral agent came into market or discovered in 1950. We thought we have conquered the madness of type 2 diabetes with the oral agent. However, the fact is that uncontrolled diabetes is rampant, not only in India, but also the other parts of the world, and many of them with the target organ damage. I say not many, but most of them. We all are clinicians. Everybody, we all are, who are listening to me today, we all are clinicians, and every day we see patients with severely uncontrolled blood glucose, either on inadequately doses of multiple drugs or multiple drugs with the maximum doses, like my patient Mr. Kumar was, for a couple of years with A1C more than 10, but not on insulin. Worst clinician had never discussed the option of insulin, the typical case I have presented here. Now, the scenario is that today, when we go by an evidence from your developed country of UK, the data from 2005 to 2017, the A1C is almost constant. The A1C control less than 7 is near about in 31%. It is always constant, despite we have got a large number of the medicine discovered since then. Large number of the armamentarium of the drugs available, including injectable, the A1C for years together. This is not in India, but over, this is the scenario of the developed country like UK and USA. And worst part is that the person, the patient, if is on insulin, the A1C control is worse than that on OHA. The reason I will tell you later on. So this is the natural history of the diabetes, and this slide I like always. And when I teach my students, this is the favorite slide I love to have. The natural history of diabetes is progressive beta cell failure. And when once the diabetes is diagnosed, nearly 50% of the beta cell is knocked out functionally and morphology. Only the diabetic patient is left with only 50% reserve of the beta cell. And as of yesterday, I just received in 2021 ADA treatment algorithm. It happens in a step later manner. Again, that's still the emphasis on add-on drug to diabetic patient. First of all, we add lifestyle modification with your monotherapy, like our patient was on monotherapy, and then we add another. And what I call it, the treatment paradigm is waiting for failure. Once the drug is failed, we add another drug. This is the treatment paradigm is waiting for the failure. Once the drug is failed, then only we add another drug. And a lot of year is wasted. What is the outcome of this treatment add-on drug is that our patient remained in the glycemic burden for 10 years with A1C 9.6. Why? Because there is a therapeutic inertia. Because in clinical practice, there is inadvertently delay in the intensification of the therapy. Now, once we add metformin, like in Mr. Kumar, the second drug takes near about 2.9 years for the addition of the second drugs. Once we have added the second drugs in clinical practice, it takes near about 7 years to add the third drug. And after adding the third drug, it takes near about another 6 to 7 years to add of the insulin. And total time is near about 1 decade, and A1 is more than 9. Like Mr. Kumar, typical history of Mr. Kumar that I presented is that more than 10 years and A1C more than 9, it is 9.6, and we had the maximum number of the drugs. Why this is bad? Because the person remained in a what I call this word, in excessive glycemic burden, that I call avoidable excessive glycemic burden. This is avoidable, that's why I use the avoidable. Despite therapy, the patient remain in avoidable excessive glycemic burden for years together. And we know the excessive glycemic burden for the years together invites the chronic complication of the diabetes. And we treat the diabetes and we invite the chronic complication. This is the biggest disadvantage how we are treating the diabetes in today's scenario. And this is the real world scenario. When the patient is in excessive glycemic burden, after 5 years, the A1C remain more than 7 years, there is the patient in a UK study of 1 lakh patients, the receiving ODA, and there's 1 delay in intensification of the treatment. And patients remain for years together, 5 years in excessive glycemic burden. There is an increased myocardial infarction by 67%, stroke by 51%, heart failure by 64%, and composite cardiovascular event by 62%. More than 60%, we treat the patient, but we invite the complication. We don't intensify the treatment when it's necessary. And there is a direct correlation between micro and macrovascular complication to the A1C level. This is the evidence-based medicine that I am putting here. And why it happens when we go, chronic hyperglycemia is a driving factor. When I teach my student, diabetes is a metabolic disorder of the carbohydrate, but it bites the vessels. So once the patient is on excessive glycemic burden, because of your reduced oxidative stress and inflammatory response, it bites the vessel. And there is the atherosclerotic changes both in major and minor vessel. And because of this atherosclerotic damage in the vessels, it invites both macrovascular and microvascular complications. This is the most drawback when patient is in excessive glycemic burden. So this is the diabetic patient. All other diabetic patients who are undergoing dialysis in my dialysis care unit, and these are patients in surgical unit admitted with your uncontrolled diabetes, not on insulin, with a chronic complication. We invite as per the evidence also. And can we see it? It is the Dr. Mohan's study in 2011. By that time, in India, we had got near about 17 million diabetic kidney disease patients. 17 million in 2011. We don't know what is today. And 11 million of your heart, coronary disease patient because of diabetes. And near about 17 million because of your diabetic foot patient in 2011. Can we see the huge burden? And the huge burden not only reflect your diabetic complication, huge economic burden also. So when we talk about the excessive glycemic burden, this prolonged avoidable glycemic burden, I call this avoidable glycemic. This prolonged glycemic burden can be reduced if we institute insulin therapy at any time in the natural history of the diabetes when it is most appropriate and it confers the maximum benefit by achieving the glycemic control and preventing the complication. Since we are most of the time instituting the insulin therapy very late, we can induce it. We most of the time put the patient on insulin after 3, 4, 5 drugs. But if we put it in the natural history after second drug, even at the time of the diagnosis, it has got beneficial effect. Let's see it again. So how early we should put the patient on insulin? There's 3 ways to put the patient on insulin. Either we put the patient at the time of the diagnosis, or when there is this is secondary oral hypoglycemic agent, and once patient has developed complication. Now let's see in which stage the patient are mostly treated with the insulin. Now, what is the advantage? I can say this presentation might seem to be something unique or not practical today, but I will give some evidence that putting the patient at the time of the diagnosis is beneficial or not. So there is a evidence from your American College of Clinical Endocrinology, which clearly say if A1C is more than 9, particularly when there is a osmotic symptom, they also advise to put the patient at the time of the diagnosis on insulin. These are guidelines, 2020 guidelines of American Institute of Clinical Endocrinology. And that too, in 2020, just yesterday's guidelines of 221 of the ADA, they also say we can put the patient at the time of the diagnosis if A1C is very high, particularly in a symptomatic patient. The both international guidelines do recommend insulin at the time of the diagnosis in selected patient. Now, this is the study I undertook in Himachal Pradesh, and the first study in India, and a very prolonged study, and I followed up them 3 years. So I took 122 newly diagnosed diabetes in my institution with A1C more than 9, and I treated them for the initial 2 months with pre-mixed insulin 70-30 and metformin. After 2 months, I took out the insulin and put them on OHA depending upon their A1C level. Can we see the average A1C dropped from 11.5% to 7.3% at the end of the 2 to 8 weeks, 2 months. 4.5%, near about 11.45. There is near about 4% fall in A1C in 2 months when I put the patient, and there was metformin on. And can we believe the A1C was 7.15 at the end of 3 years? At the end of the 3 years, the A1C was 7.35. 88% of the patient achieved A1C less than 7 at the end of 8 weeks, and 76% achieved A1C less than 7% of ADA goal at the end of 3 years. There was only less than 1 episode of the minor. There was no major hypoglycemia. The 0.9 means less than 1 episode per patient. Minor, that was only minor, mild. Compared to later on when patient OHA, they had more than 1 episode, and that was moderate. And 113% out of 120 was very, very satisfied with that. Very satisfied with the treatment. This is my personal experience with at the time of the diagnosis. And this is another study where the glargine was instituted at the origin study, where the glargine was instituted at the time of the diagnosis. Can we see the glargine and your standard of the care patient? There is a difference because the A1C was in the beginning also very low, 6.4 only. It was then study done in one pre-diabetic patient. So we can say there was this, though it was very small, but because of the initial A1C of 6.5, there was a reduction in A1C with glargine at the end of 7 years, and the person who was standard care, near 12% required insulin, but none of the patient in glargine required intensification of the treatment. So it maintained the glycemic control up to 6 years, and there was no need of intensification, wherein standard of the care, 12% was shifted from oral agent to injectable at the end of the 6 years. What is the advantage? There are 2 studies. I love this study, DCCT and ADDICT, followed by your UKPD study. DCC is related to a type 1 diabetic. When we intensely treat the patient at the time of the diagnosis, there is a statistically significant reduction in the microvascular complication. That is retinopathy, nephropathy, and neuropathy. That is the evidence from your DCC trial. ADDICT is then follow-up of the DCC trial. At the end of the 10 years, after the end of the DCC trial, when the patient was followed up with your mixing of your uncontrolled putting on insulin and insulin patient not taking the insulin, at the end of the ADDICT is a follow-up of this patient. Even after the A1C reduced intensive care, it reduced, there was still a beneficial effect of intensive care at the time of the diagnosis. So this is what called a memory effect of these. So at the time of the diagnosis, if we treat the patient with the reduced A1C, it is not only the initial but long-term effect of reducing microvascular and macro. And that too was replicated in UKPDS trial. There was a significant reduction in micro and macrovascular complication when patient intensely treated at the time of the diagnosis. So initial treatment is always beneficial, and it not only reduced in the short term, even later on, if there is a deterioration in glycemic control, it confers the benefit, what we call as the glycemic memory. So question arises here, despite evidence of benefit of early tight glycemic control, how commonly insulin is used at the time of the diagnosis? I am asking this, or I am putting it to my viewers at the time of the diagnosis, even in patient who is symptomatic. So the answer is in front of you, I think very, very rare. But if my personal experience, I'm putting a lot of patient, it is good from the patient point of view as well as physician point of view. Why? The patients, the A1C is well controlled, and physician, the satisfaction is very high. To initiate insulin at the time of the diagnosis for short duration, I don't say only for 2 months or for 4 to 8 weeks, in selected patient, particularly when A1C is more than 9 with symptomatic patient. That is my carry home message here. So it is very, I can say in real practice, nobody is putting that at the time of diagnosis, but it is good if somebody put it when it is indicated. But most of the time we call when OH is failure, like Mr. Kumar, where OH is failure, but not 1, 2, 3. The insulin is indicated when OH is failure. Now, how common this is done in your clinical practice? When OH is failure, Is it a common scenario here? So this is the study from not only in India. There is in clinical practice, we wasted a lot of time. We wasted near about a decade, and A1C is skyrocketing high as evidence from the previous study. But this is, I am giving a latest study from Australia. Australia is a developed country where to put the insulin, it takes near about 11 years to initiate the insulin in type 2 diabetes. So it is an inadvertent delay, not only in developing country like ours, but world over. So we don't, once the patient is treated with OHA, we maximum push the patient on OHA for decades together. Like in Australia, it takes 11 years to initiate the insulin average. Okay? So now this is my personal data from IGMC. I screened 259 type 2 diabetic patients admitted with chronic complication in my unit. And the average is, we know that the average duration of diabetes was near about a decade, and average A1C was near about also more than 9. Can we believe only 11% of the patient were on insulin prior to development of the complication? And these 11%, 12% of the patient were mostly either taking treatment from your postgraduate institute of Chandigarh, Indira Gandhi Medical College of Chandigarh, or corporate hospital of the Chandigarh. And 88% were not taking insulin, were not prescribed insulin until they develop one or another type of the complication. That is the scenario, real world scenario even in India today. Insulin therapy replaces the hormone deficiency. Now my carry home here is, insulin therapy replaces the hormone deficiency associated with progressive beta cell failure. This is a very simple scientific statement. Insulin therapy replaces the hormone deficiency associated with progressive beta cell failure and can be considered at any point in the spectrum of the case. This is very important. It is considered any time because it is an hormone that is deficient and with a progressive beta cell failure, and can be, don't wait for, you have to wait for OHA failure. Insulin should not be considered the last resort as most of the patient and doctor think, but part and parcel of the disease course in type 2 diabetes. That is my home carry for you people. Now ultimately we reach, when we put the patient on insulin is when patient is developed by the kidney disease, diabetic foot, coronary disease, heart failure, so forth and so on. Patient is on one or more than one complication, we put the patient on insulin. That is the real scenario. Now let's go for this. What is the disadvantage? This is the elegant study that I projected. If we add the insulin after the failure of one drug, and if we add the insulin after the failure of the 2 drugs, and if we add the insulin after the failure of the 3 drugs. So early institution like putting the insulin after one failure is 1 or 2 drug is more effective. It is associated with less hypoglycemia, and long term it is cost effective. The 3 important factors. So when it comes to the insulin titration, when it comes to the insulin initiation, time is the most important. My dear colleagues, time is the most important. Delaying insulin expose patient to more risk of diabetes-related complication and higher overall health cost because of the complication, and timely initiation of the insulin associated with reduced healthcare costs. This is what is the time is the more, I don't say put it at the time of the diagnosis, but time is the most important. The early we put this the evidence we have got, the more effective it is, less hypoglycemia and preventing the complication, hence cost effect. So this is what is the disadvantage of late in when we put the patient. Let's see, my Mr. Kumar, I put the patient at this stage after 10 years. A1C more than, we are consuming all the drug. Now, most of the things we are doing in your clinical practice, there are 2 disadvantages. 1, it leads to excessive glycemic burden. The excessive glycemic burden for 1 decade is the main driving force for the development of chronic complication. More important is that initiating insulin once complication had developed, it is difficult to achieve glycemic target because of the hypoglycemia. So when we see it here, it is not visible here. Can we see this is the patient is on 1 OHA, this is on 2 OHA, this is on 3 OHA, and this is on insulin. When we put the patient on insulin after 3 oral hypoglycemic agent, near about 70% will not achieve ADA directed goal. In 70%, the A1C will remain more than 7%. While when the patient is on 2 OHA, near about 62% is on will achieve the goal. When we put the patient later on, only 36% will achieve the goal of A1C. Why? Because we are putting the insulin when it does not confer any bit, and we are very reluctant because we can't increase the dose because of the fear of hypoglycemia. So now going back to Mr. Benting and Charles, this is the slide I love to have. What was their goal? It was not a profit. Like any discovery today, it is not a profit, but ensuring that speedy means act fast, ensuring the fast and safe. It should be safe availability of the discovery to the public. Their only concern was availability of the insulin that is safe and it should be easily available. But unfortunately, insulin being the oldest, being the natural, and being the most potent, anybody say it is more? I think most potent, even analog is the insulin. Even these what you call GLP, but insulin is the oldest. It is a natural. It's the most potent anti-diabetic agent available. But the sad part is that least commonly used anti-diabetic agent in clinical practice. That is why I have come here today. So, and this is the Lancet study of 2018 endocrine Lancet study. Can we see only 7.5% of the diabetic population, average A1C of in the world diabetic population world over is 9. Only 7.5% are using insulin in type 2 diabetes, despite A1C globally is more than 9. And the worst part is in Asia, where only 6.4% are using insulin. After Africa, of course, I don't count Africa because of many reasons, but in Asia, including India, only 6.4% are using the insulin. And it's an unmet need, it's the largest relative unmet need in Asia. That's why I choose this topic very, very consciously, because why we lack in initiating when it is required. So the question arising, how to initiate and intensify the insulin therapy. With this background, we will go how to initiate the therapy. Now, here is the clinical scenario. Here is Mr. Kumar, who is 55-year-old, non-diabetic for 4 years, presented in my outdoor department with A1C of 8.9, fasting 160, postprandial glucose 243. Medicine he was taking was metformin 2 gram and glimepiride 4 milligram and teneligliptin 20 milligram, but still he's 8. Now we don't have any option. We can add many drugs, but as I told you, this patient is the patient who we can put on insulin. So question rises, should insulin be the initiated to Mr. Kumar? If yes, how should it be initiated? So when should the insulin be initiated in type 2 diabetes? This is the first question. When we go by ADA, EAST 2020, even today 2021 also, lifestyle modification morphine, when patient is on combination of 2 and 3, still A1C is more than ADA target of 7, insulin therapy should be added. The first answer is by ADA. Once patient is on combo of 2 or 3 and A1C is not at goal, add insulin. And this is again put forward by ACE 2020 guidelines also. Once patient is combo of 2 or 3 drugs, put the patient on insulin therapy. Now real world scenario, practical scenario here, I'm putting it to everyone. Nearly 50% of type 2 diabetic patients need insulin 5 years after their diagnosis. Near 50 years. My patient is 4-year-old. 50% of type 2 need insulin after 5 years. Now, this is very practical. If A1C of the type 2 diabetic patient remain elevated above 8.5, this is a very important statement. Despite on 2 oral agents, let it be metformin and glimepiride, let it be metformin and pioglitazone, both potent. If our patient is on 2 drugs and A1C is 8.5, it is highly unlikely that addition of third oral agent will bring it to the guideline recommended level less than 7. And this is the right time to introduce insulin to reduce less than 7. This is very, very important statement here. Once the patient is on 2 or even 3, A1C is more than, because maximum oral agent, the best oral agent, will bring down the A1C to 1 to 1.2% on. It will not bring to more than. So the ADA do recommend if A1C is more than 1.5 of the target, the single agent will not bring it to the level. This is the time the patient is already on 2 or 3 and it is more than 8.5. And this, my patient was 8.9 on 3 drug. He was the person fit for to initiate the insulin here. And this is evidence-based medicine come from NICE guidelines. The NICE guideline on insulin initiation say add on to dual oral therapy once A1C has risen to more than 8.5. They also have the same statement. Add the insulin once a patient is on 2 oral drug and put A1C more than 8.5, add insulin therapy. So this is the answer I have given when to give. So Mr. Kumar was on 3 drug and A1C 8.9. So this is the right time to add insulin. Now question rises, how to initiate and what type of insulin. So to say international guidelines, the first they say once the patient is failure, always add basal insulin. So this is by ADA to 2021, and this is by also by American Institute of Clinical Endocrinology. Once the patient has to put, it should be on basal insulin, and the dose of the basal insulin is depend upon the A1C level. If the A1C is less than 0.8, if the A1C less than 8, add 0.122 unit. That means near about, if our patient is of 50-60, near about 10 to 12 unit, we have to give at basal insulin. Or if it is more than 8, you can add near about 12 to 15 unit, depending upon the weight of the patient. So this insulin should be given based on this. We have to start with basal, and this is the dose we have to start with. Now, these are basal insulin we give. Three types of the basal we have got: NPH, glargine, detimer. The first lesson is here. Once we add the basal insulin, these are most commonly degludec. I have not put here. The most commonly available in India is this NPH, glargine, detimer. So once we put this patient on this, please continue the morning OHS. Continue the oral ion sulfonylurea when you are putting a patient on basal insulin. And your target should be to bring the fasting to near about, it depends upon, it should not be very strict also. It should be less than 130, between 100 and 130. That should be your aim. So start and any insulin with your 10 to 12.2 unit per kg body weight as per A, but give them morning dose of the OHA and then titrate your fasting. The target of your basal insulin is to target the fasting to the level of 110, 120. And I ask the patient to go for your fasting glucose every 3 days. If it is not in target, increase the dose by 10% or 2 units every 3rd day till you achieve the target. So ask a patient to go for your maybe once in a week, see the fasted sugar. If it's not controlled, increase the dose by 2 units till it comes to target of 110, 120, depending on that. And morning has to be continued. So this is the way why we choose this NPH, detimer. The NPH at near 10 to 12 hours, detimer is 18 to 20. And though it is not 24 hours, I disagree on this point, but maybe 20 to 22 hours of the glargine. So this is the profile we are giving to our patient when we give OHs. Now, which basal insulin is it? So most of the time when you go to the international conferences or national conferences, it is always analog, either glargine or detimer, not detimer, glargine, everywhere glargine, lentils, glargine, lentils. But today I want to say you a practical aspect. So you add anything, you add NPH to HS to your glyburide to metformin to glyburide to metformin and any of your glargine, there is a significant reduction in the A1C. It ranges from near about, I can say near about average 2% reduction in A1C at 12 months. So average, you add glargine, you add whatever NPH you want to add, the A1C reduction is almost similar. There's no difference. Whether you add glargine or detimer or you add NPH, it is almost same. It brings down to the same level and almost near about 1.5 to 2% reduction with all the three. So all the three bring about the same amount of reduction of the A1C, and that is maximum in the first year after initiation. So now there always comes in your mind when you go to conference, there is a type of some hypoglycemia with your NPH. So this is put to the rest by your what you called by meta-analysis of your 6 randomized control trial. When the basal insulin reduces the A1C to the same level, A1C to the same level. I told you in the beginning. So whether you use NPH, we use detimer or degludide or degludec or detimer, they bring the same amount of the reduction except for your NPH in very small doses. So once the NPH you increase, it almost bring to the same level of the reduction. So all the basal insulin bring about. So now today onward, I will say it very clearly, having evidence suggests all basal insulin are equal in reducing the A1C. There's no advantage of one over the another. The second question arises, hypoglycemia. Let me tell to be, meta-analysis of 6 randomized control trials revealed no difference in the event of the hypoglycemia, particularly in the event of the severe hypoglycemia. So once NPH, determined NPH in 2 doses, or only when you use the 2 doses, or once when it will occur with NPH, when we will try to bring down the fasting blood glucose to less than 100. So keep only one aspect in mind. Once we give NPH to the this human insulin to the patient, never try to achieve the fasting to near about 100 or less than 100. Try to keep it between 110 120. The maximum hypoglycemia is seen when we try to achieve the fasting less than 100 or less than 110. The only if you want to prevent the hypoglycemia, otherwise there's no difference between NPH, glargine, and detimer in the rate of the hypoglycemia. So 2, they bring the A1C to the same level, and there's no significant difference in the hypoglycemic event with any of these. So, re-emergence of human insulin. In a full day session on the use of human insulin clinical practice was discussed in 2019 ADA, and everybody recommends human insulin instead of analog as a preferred insulin because of the cost effect. And this is replicated by NICE guidelines which say NPH is the preferred once or twice first basal insulin. And let me tell you, the Indian guidelines, the South Asian guidelines of your Japan's, of your Chinese, and many other do recommend. This is by the NICE guideline again. This is not the developed country guideline. NPH is the first basal insulin one should. And this is replicated by your AD in 2019. And I will tell you later on in what was the outcome in yesterday's monograph of your ADs. So this is the last I have taken it just today in the morning when I went to the insulin of this. Cost of insulin is rising steadily over the past 2 decades and contributes significantly burden out-of-pocket cost. So AJ 2021, that is just yesterday only, has recommended the human insulin by the NPH regular appropriate choice of the therapy, and this is what the addition of the basal insulin. First they have put it either human NPH, analog later on. So even the ADA has put in 2020 NPH, the human insulin. Because of the rising cost, people are not taking it. So there's no difference in hypoglycemia. Why to use analog? This is just a propaganda. I don't say this is much more than that. I treated Mr. Kumar with the NPH 12 unit at 10 p.m. and metformin 1 gram twice daily and glimepiride 2 milligram in the morning before, as per the guidelines. I put him on this. Now what happened to Mr. Kumar? So I asked Mr. Kumar, let me tell you very clearly, if he had NPH, it should always in the evening. But Glargine and Levimir had no preference time of giving it. It depends upon the patient when the patient wants to take it because it has got long action. So I will ask my patient in Glargine Levy, if he is convenient in the night, take it in the night. Otherwise, he can take any time as and when he feels he is convenient for taking this, that, and this is evidence-based. So I asked Mr. Kumar to titrate the insulin every 3 days and add 2 units. It will more than target. Increase the NPH by 2 units if it is above than 130. And so try to bring it not to 100, but I asked him to keep it 120 only. So Mr. Kumar came back. At 2-month follow-up, A1C was 7.8, fasting was 106, and post-prandial was 249. His morning glimepiride dose was increased to 4 milligram. Mr. Kumar had up-titrated the dose of NPH to 20 units to bring it back to 106. But when he came out after 8-9 month follow-up, his A1C was 7.6, near about to target. Fasting was 89. And post-prandial was 229 with 12 units of the NPH. This is the most time the scenario. Within 1 year, you encounter the basal insulin. So once we put the patient on their first insulin, basal insulin, near about 40% of the patient achieve A1C less than 7. Don't be realistic. Don't think I put the patient on insulin, all will get the A1C to the target. It is only 41% who will achieve the target of A1C. And this is why, because once we have got 2 types of the blood glucose. Once it is in a pre-lunch or what kind of fasting glucose, and then it's a post-prandial glucose. Of all the 3, it is fasting, post-breakfast, pre-lunch, post-lunch, before insulin, and it is pre-dinner and post-dinner. So I pushed Mr. Kumar on your basal insulin. It brings the whole scenario of the insulin to down. Whole of the blood glucose standards put down, but no difference between fasting and postprandial. Postprandial always remain to the same level. So when I see the difference between your fasting here and here, that is pre-insulin and post-insulin, it has come down, but the postprandial has come down, but the difference between fasting and postprandial remain the same. So it brings whole of the blood glucose to the down, but the postprandial remain almost elevated. The most drawback of the basal insulin, it does not cover postprandial insulin. That's the biggest drawback. And what is the maximum dose that you can increase the basal? It is recommended, please increase the basal. The basal maximum dose, the most effective dose of basal insulin is 0.5 to 0.7 international unit per kg per day. You can't, suppose my patient is of your 60. So maximum 30 I can go. Beyond 30, it will be counterproductive. So you calculate it, maximum dose they say, every organization say, maximum dose we have to go is 0.5 international unit, but you can go in some 0.7, but the maximum is 0.5. Beyond that, it is not effective. It will produce more hypoglycemia in the night then. Second, most of the basal insulin has been shown the effect reduced after 1 year. So most of the basal insulin has been shown to be effective after 12 months. There is a deterioration in the blood glucose level. So there are 2. One is the dose, how much maximum dose, and how much time it will be effective. So 1 year and 0.5 unit is the maximum dose. Now I give you a very practical aspect. You, when the patient put on your any basal insulin, you determine the bedtime blood glucose and you measure the pre-breakfast fasting blood glucose. If the difference between the bedtime and fasting is more than or equal to 45, it is more than 45, then if it's there, there's no need of giving further. When the difference is less than 50, only then up-titrate the basal insulin. This is the simplest formula I have given. So measure the blood glucose at bedtime, measure the fasting. If the difference is less than 50, up-titrate the basal insulin. If the difference is more than 50, down-titrate the basal insulin. What we call it as over-basalization. What happens when we increase the dose to more than 0.5, the fasting sugar will come down to less than 90, 80, but the postprandial will remain the same, and patient will having the feature of your nocturnal or fasting hypoglycemia. No advantage in reducing the oral A1C. That is a disadvantage. So what we'll do once the patient reaches to 5.57, like my patient at 8-month follow-up, his A1C was not at the goal. His fasting 89 and postprandial was 229 with 22 unit of. There was no need because I reached to the 0.5 unit. Maximum fasting was coming here. Further increasing NPH was associated with your hypoglycemia. So how should Mr. Kumar postprandial be addressed? So what does the recommendation says? The recommendation says that once the basal is failed, add the bolus basal plus. That means basal plus means they say if basal is failed, this is AD recommendation, add what you call basal insulin before the largest meal of the day. Second is the largest meal you have to determine in your patient. Then add how much add? 20% of the basal you add the bolus before the largest meal. Like patient is taking 30 unit. Okay. Then you calculate the 4% of that near about 12% of your 30 unit is near about your 12 unit. So give that 4%, or you can start with the minimum of your 4 unit. The best is your 10% of your basal. That comes out to near about 3 unit, or they say 4 unit you start with the largest meal. You have to determine the largest meal of the patient. This is what we call this as a stepwise basal bolus therapy. So what you do, you determine the patient's largest meal, add insulin, that is the regular insulin before main meal, and that is either 4 unit or 10% of the basal insulin. And once this is covered, then you determine the second largest meal and then the third largest meal. So this is the way we call it basal plus. This is called basal plus. You add first one regular before the largest meal, second regular before the second largest meal, and then the smallest meal. This is the way we go until we achieve the A1C of less than 7, fasting 110 and PP less than 180. This is called basal plus bolus transition from your basal to intensify the treatment. So this is a two-way. I begin with prandial insulin. If not goal achieved, 10% or 5 before each meal, or you can do basal bolus from the beginning also. 50% basal, 50% bolus. Okay. So if we add one drug, if we add one bolus or 3 bolus, they bring down the A1C from your 10 to 7, almost to 2% reduction in the A1C, basal bolus. Whether you add 1, then you add 2, then you add 3, all the 3 will bring to the same level because you are adding the drug once it is failing. So it is very effective to reduce it to the same level. So here it is with the basal. So once it is with the 1 injection, it has come down with the largest meal, then with the second, and then with the third, but it remains throughout the same. So how much it is in practical sense, once we add the patient shifted from basal to basal bring to the level of 41%, there is only additional 12% to 14% increase in A1C level with basal bolus. That means A1C is brought down in 41% to less than 7. Here it is only 55%. Be practical, be realistic. Tomorrow the patient will come to us and say, Dr. Saab, you have put us on the 3 drugs, but still A1Cs. We should be very realistic. Suppose here it is a 50%, then it is near about not more than maximum 66% of the patient, 2/3 of the patient will achieve A1C even on basal bolus therapy. That we have to keep in mind. Be realistic. Okay. But here the query is that we are talking of your USA, because my ADA comes from the USA. But I will put my views from the Indian perspective here, what I have seen in life and what the literature says. So what is the disadvantage, and that you will agree with me, basal bolus in Indian context, basal plus or basal bolus. Okay, so though effective, it is effective, near about 66% will bring down the A1C level, but at the cost of multiple injection. So of different type of the insulin, you are giving one basal, another your regular insulin, there is weight gain and there is more hypoglycemia. This is what you are giving to the patient. But more important is that you have to know the meal pattern of your patient. Largest meal of the day. Is it possible in India? Except those are living in very good metros, that is different. But somebody is coming from the village. Think of the Punjab, Haryana, Uttar Pradesh, Bihar, and in my state. The real problem in India is that the food pattern vary with the region, religion, and local customs. Like in where I stay in the northern India, breakfast and dinner in my area is the highest. If you ask them, they say, I take dinner with my family and breakfast is most of the time is very heavy. And Indian food are very rich in carbohydrate. When I calculate in my areas or world over in Indian, 70 to 80% are carb in the diet because we are vegetarian. Hence, it is difficult to know the largest meal in our patient. Therefore, difficult to decide which meal to add the first bolus. So if it's difficult to understand, then we have to, second option, we have to go for 4-point blood glucose values. Fasting, 2 hour post-breakfast, lunch and dinner to know the highest post-meal glucose rise. Now go back and just pause. How many people will agree for in a single day for 4-point glucose? These are real value. When we go to conferences, they will go out, vomit out the AD and AST guidelines, but nobody talk of this real fact that we encounter in day-to-day practice. So not possible. So considering this practical issue in the use of basal bolus insulin in India, the basal plus bolus insulin therapy, though recommended by most international guidelines, not suited for most type of patient in type 2 diabetics seeing their demographic profile. Now, what is the evidence for this? Mr. Kumar was asked, which is the largest meal? He was not very sure first, but his breakfast and dinner both are very heavy and are heavily loaded with carbohydrate. And that everybody who are listening me must be agreeing with this statement also. And he refused for 4-point time blood glucose profile. Dr. Saab, mere ghar mein to kuch bhi nahi hai. How can I do it? I live in the villages. However, after insistent and discussing with him, he agrees for one time ki ek baar mein karunga, 1 time 4-point glucose profile. And what was the 4-point profile? Fasting was 91, post breakfast was 219, post lunch was 206, and post dinner was 230. All the three. How can I say which one is the largest meal of my patient? This is the biggest issue we are facing in India today. That's why the basal bolus does not have so much. And let me put it is not only in India. I was going to the Thailand guidelines. I was going to the Chinese guidelines. Everybody agreeing. Practical problem with dealing with this basal bolus in our side. So we have got another option. Can we put the patient on pre-mixed insulin? And that is by the ADA and EST, and this year ADA is also recommended the same way. After basal, if it is failure, we can directly shift the patient to basal bolus. One thing, or we can, instead of the basal, we can start the patient at the time of the diagnosis with the basal pre-mixed insulin also. Is there evidence today? Yes, today we have got evidence. WHO, Indian RST guideline, and most of the other Asian nations, Thailand, Chinese, do recommend human pre-mixed insulin as an initial insulin therapy, not a basal insulin. One thing. Second, let me put it a nice guideline again here. Consider starting with twice daily pre-mixed human biphasic insulin, particularly A1C exceed more than 8.5. Biphasic insulin analog may be chosen if immediate injection before meal is preferred. So even with us, with Indian guidelines, with WHO guidelines, even the NICE guide do recommend if we had to start with pre-mixed insulin, maybe once or maybe twice. It depends upon the level of the glucose. And this is what we have to think in Indian perspective also. So now, Indian guidelines, or if patient is already on basal, divide the daily basal. If somebody has put the patient on basal, they want to change it. See, suppose my patient is taking 30 units, I will say 15 pre-mix in the morning, 50 into equal. 1-to-1 ratio. But once you start the premixes at the beginning, you want to start not the basal insulin. This is the dose, 0.3 to 0.5 unit per kg body weight, and divide 2/3 in the morning and 1. Start after the basal insulin. Once the patient is on basal put by somebody, he comes to you, you can divide the basal insulin to 2 half. Or if patient is coming to you directly, you can directly start with the insulin algorithm based on pre-mixed insulin 730, 0.4 to 0.5 unit per kg body weight. Suppose my patient is of your 60. So I will start with a 30 unit, means 18 and 12. Or I can start with 28, and that is 2/3 in the morning, like 16 and 10 also. All these I will start in my patient, and this is the recommendation. But here important point is, once you have started twice pre-mixed insulin, discontinues sulfonylurea, glitazone, DPP, and this. Only keep metformin. That is the home carry message. And give one pre-breakfast and pre-dinner, half an hour before the meal. So there's 2 ways. Now one is basal. And once the patient is on basal, you can divide the basal into half pre-mix both, or you can give the patient at the time of the first encounter with the patient with your 0.4 to 0.5 unit per kg body weight, with 2/3 in the morning and 1/3 in the evening. So it is effective. It reduced the A1C near about to 1.5 to 2%, and twice daily premix is much higher as compared to your. So, but it has got disadvantage ki maybe it is more effective. When it is more effective, it causes more hypoglycemia. Mind it again, the recommendation of the guidelines tell you the hypoglycemia is only when we'll try to bring down the fasting to less than 130. That means if you want to give premix or human insulin, we try to achieve the fasting of 130 we will see the hypoglycemia. Once we will try the fasting to 110 between 120, the hypoglycemia is as usual as that of the glargine and etimir and deglutide. So do not try, once we give human insulin, try to keep the fasting to 120. That is the so premix versus basal bolus insulin. Basal bolus is said to be better glycemic control than premix, but at the cost of inconvenience. That is more injection, weight gain, more hypoglycemia. Intuitively, this is very important, and this is what I have found in my practice. It would probably be easier for the patients and the physician to adapt to more frequent injection of the same insulin. That is the premix, same injection. Compare with adding another type of insulin. Once you are basal, then rapid injection on another. That's a very big issue. Second, regiming complexity is the most common barrier of your non-compliance to the insulin. So always try to keep as simple as possible. So regiming complexity of basal bolus is a factor associated with poor compliance, because complexity is the most common poor compliance. Once patient is going basal, there is a 79% acceptance rate. Once it is shifted to a twice, pre-mix 66, but once basal bolus, only 1/3 we go for. So when there is no compliance, what is the use of putting the patient on basal bolus? So near about at least 66% will achieve, we are compliant when we give pre-mix insulin as compared to 33. Near about double compliance is increased. Okay, and this is what is put by basal 2021. Sorry, here again change to pre-mix twice daily. Again, once basal is failure, you can shift rather than go to basal bolus, we can shift to your pre-mix insulin given by ADA 2021. So based on this recommendation, Mr. Kumar was shifted to a premix human insulin 16 to before breakfast and 12 units before dinner, and metformin glimepiride was taken out. His glimepiride discontinued. At 3 months of the follow-up with up titration of premix 20 units before morning and 16 units before dinner, Mr. Kumar AVOC was 619 and fasting was 102. Postprandial was 169, 153, 175, and respectively with no hypoglycemia. That's the scenario in our case. Now, there are some patients who's coming to us and they are saying, no, doctor, I am not taking an insulin. We have got another option to it. So once the patient is on basal insulin, we have got two. One is that if somebody is affordable, we can say what you call as a basal insulin plus. What we can do, we can go either from basal to basal plus and basal bolus, which is very cumbersome. If patient denied, what we add in the morning with the patient is with your OHS in the morning, we can add SGLT2 inhibitor, we can add DPP inhibitors if oral. If somebody agreeing, we can add basal, what we call GLP analog in the night. So if patient is not agreeing for the this injectable, the best therapy is give the basal in the night with metformin and add with your metformin and glimepiride or your sulfonylurea, you can add SGLT2 inhibitor and DPP. This has become the latest if you want patient is reluctant to use more than one injection. That is just for the reference. On Saturday, Mr. Deepak, real world scenario. On Saturday, that is on 5th of December, Mr. Deepak, known diabetic for 3 years and was diagnosed with pulmonary tuberculosis 2 months back on antitubercular drug presented in my OPD for change of insulin therapy that was prescribed 2 days back by my colleague for his uncontrollable glucose. That is a real scenario we see. And his fasting was 167, postprandial was 269, A1C was 9, despite taking 2 OHs. My colleague started Mr. Deepak on injection glargine 10 units, metformin 500 after dinner, and combination teneligliptin and metformin before breakfast. Appropriate therapy, my colleague. But he changed the doctor. For the fear of, when asking why he want to change, fear of addiction, he was not willing in initiating the insulin and he changed the doctor. This is a real scenario. So now what are the barriers of insulin therapy? Why so much barriers of things? Why the patient change even the doctor and they leave you? This is something seen in daily to daily practice. We have seen it daily. Okay, now this is what is the coming barrier. When the other barriers, we talk of 2 barriers, either patient's related barrier or it is physician related barriers. So these are the patient's related, the fear of injection, feeling that insulin is too complicated, feeling that personal failure, belief that insulin cause complication, all these, and patients and provider, I mean physicians barriers, hypoglycemia, burdensome regime, poor complication. So let's go in a real world scenario today. This is what is. What are the barriers in initiating the insulin therapy and how to overcome this barrier? I am going to take in less than 10 minutes. So when I ask you the physician's point of view, I screened or I interviewed or I went to the 139 primary care physician in the periphery of Himachal Pradesh, and their duration of service was ranged from 6 months to 24 years in service. Mind it, 24 years in service, with average of your 8 years in service. Were asked about the insulin use in the peripheral health center of HB. Only 6 primary care physicians out of 139, that is 4.31 has prescribed insulin. This is a real world scenario. So now what was the concern? So I asked him, yes, why so much low prescription of insulin? You must be say what much the cause, but I found two reasons: fear of hypoglycemia and when to start and how to start. There were the two main reasons. They were fear of the hypoglycemia in their mind. Insulin start kiya, patient will do hypoglycemia. Second, if they want to start, but they were not knowing when to start and how to start. What is the time we should initiate and how we should start it? There are two main reasons for the physician that they were not initiating. Because why I'm talking primary care physician? Because in India, near about 70 diabetic patients are seen by the primary care physician. So now patient's barrier. In dealing with a type 2 diabetic patient in my career of the 20 years of my service, patient either in OPD or I have gone to the camps. I had taken 22 free camps in Himachal Pradesh. It was found that the maximum myths, beliefs, and misconception in diabetes was regarding insulin use. My experience tells the maximum myth is regarding insulin use. They will never come back to you or they will change the doctor again. Once you talk of insulin, that's hard fact. Okay. Now what I did, I screened near about 559 diabetic patients seen in OPD and in the camps in the periphery. And their average duration was 7.39 years and average A1C was near about 10. Only 11% of them were on insulin. Mind it, in the periphery, 11% was on insulin. And again, telling you these were only from their, not even less than 1% was by the primary care physician. So when I screened these 559 patients, 279, that means 50% were eligible for the insulin. That based on their A1C more than 9 or uncontrolled sugar defy maximum dose of the oral drug. Now what these 279 patient tells us, let's go with that. So when I went to these patients, their sugar was uncontrolled on maximum drug in the periphery. But when I asked them they need insulin, they refused. Like you people must have experienced. This is what I am discussing with the patient in the camp, but they are refusing for the insulin. This is happening in my OPD, in day-to-day clinical OPD. This is the rush in my OPD. And this lady, this all requiring insulin, but they are reluctant of because there's an indication for insulin, but they are saying no to the insulin. At the first contact, they are saying no. This is again, I'm putting a lot of efforts in my OPD also. Okay. So what I came across out of 279 patient, only 70, near about 8% of the patient accept the insulin at the first contact. 99.2% refuse. This is what I say, everybody must be agreeing with us. This is the way the patient is, that most of the patient, more than 90%, they refuse for the insulin at the first time. I think this is the practical aspect we are seeing. But what we do, this is the question here. In real clinical practice, patient refuse, but we accept their refusal easily. कोई बात नहीं डॉक्टर साहब, नहीं लगाना आपने, कोई बात नहीं, दवाई लिख लेंगे. Resulting delay in this is the conundrum here. We accept their refusal easily. But here, in fact, I will tell today to my colleagues, our work start here. If you want to initiate the insulin, our work start here. How? Educate the patient about insulin, as they have deep-rooted misconception, myth, concerns, anxiety. The question arising, how? The first thing is to find out the concern they have in your mind. Why the patient sitting in front of us don't want to take the insulin? If we don't know that, how can we give the patient the insulin? The first thing we have to understand why, what is the concern or the misconception in my patient's mind. So this is the way I try to get out the beliefs, concerns in my patient's mind in OPD. In group, I try to take out concerns, and in group, you want to say, I don't want to take the insulin. This is I put the patient. So what I found, 73% of the patient refuse insulin because they fear addiction. The word is adat in my local parlance. Adat means, Doctor Sahib, if I will use the insulin today, I have to use for the lifelong. Why? I have heard it from the community. Once insulin started, because most of the insulin in their periphery, in the patient is known to, is started when the patient has dual kidney disease, once the patient has got diabetic foot, and till the patient die, he has to take the insulin. That is the concern in most of the. It will lead to addiction once you will start, and it's a last resort. Because there were a lot of patients in my village who were on the insulin and they died, and they were on the insulin till their death. Because what were they? They had some had kidney disease, some had diabetic kidney disease, one or another type of the complication they have. This is the most common fear in the patient, at least in my area. And 24 refused because of the injection fear. Only 24, 1/4 of patient has got injection fear, and 1/6, never 17% refused because of the self-confidence. Doctor, मेरे को injection, who will give the injection to me? I am confident. Okay. In addition, 16% showed their concern regarding inconvenience of insulin, like carrying the insulin, lack of refrigeration, and so on, so forth. So this is the breakdown of why patient most of the time refuse. So and we come to them. So what I did next. So when you were in the medical school and when you go to the conference, everybody talk of the insulin is hypoglycemia and weight gain. Mind it, in India, this is none of the concern. This is all the Western concern. When you go to any conference, it is talked insulin, hypoglycemia, 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 weight gain. But this is not concern even a single patient what I have screened in my clinical practice. So what is this Sir William Osler say? Good physician treats the disease. The great physician treats the patient who has the disease. So try to treat the patient, not the disease. And this is the outcome. So it was followed in my practice by the group discussion with the family member. How I did that? I did the group discussion like this in OPD. I put the patient in and try to educate them in group. They are here. And this is in the periphery. And they are raising the question regarding the insulin here when I'm educating them. The queries they are putting there. I educate them about insulin. So I educate them, but still the most important is live demonstration of the insulin injection. After we know the concern, we educate them, then how to give the injection is the most important. That is I'm doing in my clinical practice daily. This is a group of the patient I'm putting in my OPD and I am giving them live demo how to give the insulin. This is what I'm doing it. Can you see? This is a lady who is in my OPD and she refused, Doctor Sahab, I can't give the insulin because she's a lady from the village. And this boy is her son. So I requested him to know the technique of the injection and he's learning the technique of the injection in front of me. Okay, what happened next? So can you see how fearful she is here? The son is injecting the insulin. But once it is given, can you see how smiling she is? She's smiling after injection. Oh, it does not hurt me. It does not cause any pain to me. This is what is the aftermath of when we give the demonstration of the injection. And this is what is happening here also in my OPD also. I'm giving them that demonstration and they are giving at their own. Can you see this lady is very fearful and I'm trying to give it. Now she's very cheerful and she say it is very easy and it doesn't hurt me all. This happens in my real world scenario. Old lady from the village. And this is what you see after injection, how cheerful she was. So my dear colleagues, when I started this initiation of the insulin at the time was only 7.8%. When I educate them, when I give demonstration, 35% more accepted the insulin. I have to go a long way, but 35% more accepted the insulin and total insulin accepted was only about 42%. So long way to go, but still I achieved my goal here. So now education, counseling, remove the concern and myths about habituation and live demonstration injection, remove the injection phobia and build confidence. This is very important. Build confidence about self-insulin injection in our patient and resulting in 35% more patient. In today's scenario, my 40 to 45% of the patient are on injection. Type 2 diabetic patient are on insulin. 40 to 45% of the patient in my daily OPD or in my clinical practices are on insulin based on this. I do agree with you. Economic status and education standard inversely related to the acceptance of the higher the economic status, higher the education, lower is the acceptance. I do agree on this base also. And when I went to the literature, when I see what are the barriers of action taken by the healthcare professional from USA, from UK, the 10 action we had to take, I took in previous 10 years. What is that? How to take the insulin. Show me the insulin pen. Simple injection. How to give the injection. Would remove the starting the insulin. Try to injection in the field. How small the needle is. Isn't painful. All these action I took and it came just, I went through the literature 1 month back, I found it. So all these action I took and there was all has got moderately acceptance of the insulin use in the periphery. My dear friends, once patient is sitting in front of, there are two ways to treat the patient. Either we authoritarian communication with the patient. Healthcare providers say that I am irresponsible and this threaten me. And based, this is one type of the patient will tell to the family member. The healthcare provider say I am irresponsible and he threatens me. Another is your collaborative communication. Health worker asks me why I am concerned, encourage me to try it, lets me take the delegation, this decision. All these are encouraged communication. So in my clinical practice, I say avoid this authoritarian scolding, blaming, shaming. Please encourage, support and empower the patient. The acceptance will increase dramatically. It is important to gain an understanding of the patient's background and lifestyle before initiation insulin to ensure the treatment regimen take into account the patient's need and preferences as well as clinical characteristics. They're very important. Patient's need, where is they, what is religion, what is his custom, the key to successful initiation and titration on insulin is to communicate effectively the benefits of the insulin and develop a shared decision-making process, enabling patient to feel confident in control of their treatment regime. And the only one thing I will say, time wastes no one, dear colleagues. It wastes no one. Therefore, educating the patient about timely acceptance of insulin therapy is one of the best future investment in diabetic management. I say one of the best, like LIC management, it is one of the best future investment in diabetic management in preventing the chronic complication. Education patients about the insulin myth, misbelief and benefit of timely use of insulin and disadvantage of insulin using late in the development of complication. Simultaneously, primary care physicians also need to education to avoid clinical inertia. And if somebody asks me, give him the 3 words, I will say only education, education, education. So take the time out, collaborate positively with the patient so that you are successful. So be the change that you wish to see in the world. Mahatma Gandhi rightly said, attitude is a little thing that make the big difference. Winston Churchill. My dear colleagues, a lot have been said and discussed about the benefit of early use or timely use of the insulin. However, its use is dismal in clinical practice because of the negative attitude. Dear friends, the time has come to change the attitude from not using the insulin at all and or using the insulin as the last resort where it confers no benefit, rather cause harm to the patient. Moving towards the early and timely use of insulin when it confers the maximum benefit and least side effect probably is the right approach to avoid the preventable complication of diabetes. Thank you very much for your patient tuning.